Assalamu alaikum. My name is Nafisa Fatma Siddiqui. My roll number is BP1650159. I am from 4th Prof Morning. The course number is PHT 705. The topic of my presentation is epinephrine adrenaline. Starting with the introduction of epinephrine, epinephrine is also known as adrenaline, a substance produced by the medulla inside of the adrenal gland. The secretion of epinephrine by the adrenal gland is part of the fight or flight reaction. Adrenaline is a synonym of epinephrine. And now discussing the mechanism of action of epinephrine. Epinephrine acts on alpha and beta adrenergic receptors. Epinephrine acts on alpha and beta receptors and is the strongest alpha receptor activator. Through its reaction on alpha adrenergic receptor, epinephrine minimizes the vasodilation and increases the vascular permeability that occurs during anaphylaxis, which can cause the loss of intravascular fluid volume as well as hypotension. Epinephrine relaxes the smooth muscle of the bronchi and iris and is a histamine antagonist, rendering it useful in treating the manifestations of allergic reactions and associated conditions. This drug also produces an increase in blood sugar and increases glycogenolysis in the liver. Through its action of beta adrenergic receptors, epinephrine leads to bronchial smooth muscles relaxation that helps to relieve bronchospasm, wheezing, dyspnea that may occur during anaphylaxis shock. Now, see in the diagram, we have two alpha receptors, alpha 1 and alpha 2 receptor. In alpha 1 receptor, there is an increase in vasoconstriction and decrease in the mucosal edema. And in alpha 2 receptors, there is a decrease in insulin release. Same as we have two beta adrenergic receptor, beta 1 and beta 2. In beta 1 adrenergic receptors, we have increase in inotropy, and in beta 2 adrenergic, we have increase in bronchodilation, vasodilation, and increase in glyconeogenesis. Now discussing the rational use of epinephrine. Epinephrine is a hormone and neurotransmitter, as I have discussed before, but used to treat allergic reaction, to restore cardiac rhythm, and to control mucosal congestion, glaucoma, and asthma. This medication is used in emergencies to treat very serious allergic reactions by insect stings, bites, foods, drugs, and other substances. Epinephrine acts quickly to improve breathing, stimulate the heart, raise a dropping blood pressure, reverse hives, and reduce swelling of the face, lips, and throat. Now discussing the irrational use and alternative drugs. Irrational use of an epinephrine overdose may include numbness or weakness, sweating, chills, chest pain, fast or slow heartbeats. The alternative two drugs are UVQ and adrenaclip. Now moving towards the indication and the adverse effects of the epinephrine. The indications of epinephrine include asystole, pulseless arrest, systematic bradycardia, croup, anaphylaxis, acute asthmatic attack. Now discussing the adverse effects that include nausea, vomiting, dizziness, weakness or tremors, throbbing, heart attack, feeling nerves anxious and fearful. Now discussing the dosage and administration of epinephrine. As I have the case study on anaphylaxis, so I'm just discussing the dose of anaphylaxis over here. And I have used 1:2000 solution of IM in that case study. The increase and decrease in the 30 kg weight, in both the cases, we have to repeat the epinephrine after every 5 to 10 minutes if necessary. Now discussing the dosage form and strength. I have used two dosage form, that is prefilled auto-injector or syringe for SCIM use, and injectable solutions that have different dosage dose and strength in both adult and pediatric system. Now discussing the route of administration of epinephrine, that includes endotracheal tube, intravenous or intraosseous, intramuscular or subcutaneous injection. Now moving towards the epinephrine brand names. I have discussed the three brand names starting from the high price to the low price. The high priced epinephrine is xylocaine with adrenaline, which is an injection dose drug form, and the manufacturer is Barrett Hodgson, Pakistan. And the active ingredient is lignocaine with adrenaline, and the packing is given here. Second is adrenaline, and the third one is Xylox adrenaline. All the three are injections by different pharmas, and the active ingredient in almost all the three is adrenaline and lignocaine. The first one is a very high price, above 1,000, and the last one is only 12 rupees. Now, here's the brand names of epinephrine in the form of pictures: xylocaine, adrenaline. Now discussing the main thing, that is the case study of the topic adrenaline. Now moving towards the case study. The case study over here is a 65-year-old female called her family doctor complaining pain in her shoulder. Doctor called to house and administered 40 mg diclofenac. I am at 1720 mg. Doctor left house 30 minutes post administration of diclofenac. Patient felt her throat beginning to swell, develop a rash, and felt dizzy and weak. So the case study is on the topic of anaphylaxis, in which epinephrine is used in the first form of drug. First I want to discuss something about anaphylaxis. That anaphylaxis is severe, potentially life-threatening allergic reaction. It can occur within the seconds or minutes of exposure of something you are allergic to, like peanuts or bee stings, that I have discussed before. So here I have said that anaphylaxis mechanism is somewhat like anaphylaxis for the most part is believed to arise from the activation of mast cells and basophils through a mechanism generally understood to involve cross-linking of immunoglobulin and aggregation of the high affinity receptors for immunoglobulin E. So moving towards the vital signs, that the gender is female, age is 65 years. The chief complaint is anaphylactic reaction. Now, here I have added the slide in which I have discussed the initial clinical findings and the ample history of the patient. So I am not going into this, but this is a very informative slide in the case history. Now I am going towards the observation and lab results. There are different observations and lab results of the patient: pulse rate, ECG, BP, and all that. Now the assessment. And the assessment is very simple, that anaphylaxis caused by the administration of diclofenac sodium. Now, before discussing the plan, I have to discuss the signs and symptoms of anaphylaxis. Anaphylaxis mainly show signs like swollen eyes, swollen lips or tongue, and as the case study indicates, that the pain in the shoulder, abdominal pain or vomiting. There is a very huge difference between the normal and anaphylactic patient lungs. Now discussing the plan. Here I have summarized the case study in just few things, that I am giving the dosage form of epinephrine in the form of vial, 1 mg per ml, 1 ml. Administration is simply IM. That is subcutaneous dosage is 0.5 IM every 3 to 5 minutes in required, as I have also discussed this before in the dosage of epinephrine. Effects: that alpha and beta adrenergic stimulant, as it is the mechanism of epinephrine. Reversal of laryngospasm and bronchospasm, and anaphylaxis antagonizes the effects of histamine. So here I am also telling you that epinephrine 1:1000 IM is given to reverse laryngospasm, urticaria, and angioedema associated with anaphylactic reaction. So the patient is placed on 100% O2 via non-rebreather. Epinephrine is given in the same dose that I have discussed. And here I'm telling you that this is all the plan of mine. But when I give first epinephrine dose, there is no effective change. But when I give second dose of epinephrine, it gives a very good effect. Along with the epinephrine, in this case, many doctors give epinephrine in the same ratio that I have given in this case. But along with epinephrine, antihistamines, example chlorophenamine, steroids, example hydrocortisone, inhaled beta 2 antagonist, that is salbutamol, is also given, and oxygen is also given in this case in anaphylaxis reaction. So the notes is this patient developed crushing, central chest pain, radiating to left arm and mandible post administration of epinephrine. 1:2000 IM. She became diaphoretic as a result. But first dose is not as effective, but the second dose is very effective. So the patient has abnormal changes in anaphylaxis may be noted. Acute HT elevation MI is a rare but potential complication in an anaphylaxis reaction even in young adults with normal coronary arteries. Now I have discussed all the things in this topic. I think just I have left with the drug interactions. Epinephrine, I have discussed this topic in the end because I want to discuss this after the case study. So the drug interactions of this is adrenaline has many drug-drug interactions like tricyclic antidepressant, monoamine oxidase inhibitors, non-selective beta-adrenoreceptor antagonists, general anesthetics, cocaine, and antipsychotics such as chlorpromazine are listed as drugs that interact with adrenaline. Now I am ending my presentation over here with the conclusion that epinephrine by intramuscular injection is a safe therapy for anaphylaxis, but training may still be necessary. As in the case study, the doctor given diclofenac, which show the reaction on the patient. So in emergency care, training must be necessary to minimize drug dosing and administration errors to allay concerns about its safety. And then there is a reference, and then thank you so much.